Section 3. Femoral hernia. A femoral hernia is one protruding from the fossa ovalis through the femoral ring and the femoral canal. It is common in mid-aged multipara and on the right side in most cases. There are few clinical cases only account for 5% of abnormal external hernia. Basis of anatomy. The femoral canal is narrow and latent gap about 1 to 1.5 cm. The femoral canal has an upper and a lower mouth, where the uppermost is the oval femoral ring with a diameter of 1.25 cm. The presence of the femoral canal is the inguinal ligament. Its inner limit is the nacular ligament. Its posterior limit is the pectineal ligament, and its exterior limit is the femoral vein. The lower mouth of the femoral canal is the fascia of Venus. There is an oval defect on the femoral fascia at about 2 cm from the lower and outer side of public tubercle. And the mouth is covered by the membrane, also called the lamina cribrosa. The great saphenous vein also passes through the lamina cribrosa at this position and then flows to the femoral vein. Etiology: as women has a wide pelvis and generally have aplasia, or thinning conjointed tendons and lacunar ligaments, leading to wide and loose femoral ring, and also because of the increase of the intra-abdominal pressure. The tennis make visceral will get into femoral canal through the femoral ring and protrude from the fascia ovalis. Therefore, the femoral hernia is more common in women. The hernia contents are small intestine and augmented medulla in most cases. As the femoral canal is almost goes straight down, the hernia contents drop in almost straight line, but suddenly turns forward and for an acute angle after leaving the fossa ovalis. Moreover, as the femoral canal is narrow and surrounded by tough ligamentous incarceration and strangulation are liable to occur. Clinical manifestation: the symptoms of reducible ventral hernia are mild and often ignored by patients, especially obese people. The lump of femoral hernia is not large, generally in the size of a walnut or egg, and its main manifestation is a hemispherical protrusion at the fossa ovalis. It is soft and reducible because of a rich adipose tissue outside the sac. Sometimes the hernia loop will not disappear completely after reduction of the hernia content when the patient lies on the back. As the neck of the hernia sac is narrow, the no corrosion from coughing is not apparent when the intra-abdominal pressure is increased during coughing, and some patients may feel a swimming pain and a tenesmus at the effect part. In nearly 15% cases, patients only see a doctor when an evident local pain is felt due to incarceration and when an acute intestinal obstruction shows. Hence, patients of acute intestinal obstruction, especially mid-aged women, should be examined for femoral hernia to prevent missed diagnosis. Differential diagnosis: the femoral hernia should be distinguished from the following disease. Inguinal hernia: the inguinal hernia is above and inside the inguinal ligament and in the pear shape, while the femoral hernia is below and outside the inguinal ligament and mostly in the hemispherical shape. When pressing the inner ring of the inguinal canal with fingers and asking the patient to stand and cough after reduction of the hernia lump, it is an indirect inguinal hernia. If the lump doesn't show up, otherwise it is a femoral hernia. The direct inguinal hernia is above the inguinal ligament, and an abdominal defect can be felt when examining the inguinal hexapage triangle with fingers. Varicosis of great venous vein. If the lump can be enlarged when the patient stands or coughs and disappears when he lies on the back, it may be mistakenly taken as a reducible femoral hernia. The key point of differential diagnosis is the swelling and enlargement of the curved node of the great saphenous vein when pressing the near end of the femoral vein, and it is not the case for femoral hernia. Patients subject to varicosity often accompanied by varicosity in parts of another limbs, and it makes a difference from the differential diagnosis. Lymphadenopathy. An incarcerated femoral hernia shall be distinguished from acute lymphadenitis, where the latter is often in the oval shape and free of the symptoms of acute intestinal obstruction, such as acute abdominal pain, though there may be a tenderness. The focus of the primary infection can be often found in the lower lip on the thumb side. Treatment. The femoral hernia is liable to incarceration, very likely leading to strangulation, and should be treated through an emergency operation. And the most common operation method is the macroherniorrhaphy.